nerve. So obviously two branches, so one will cross over, one doesn't. That's the optic chiasm, and then that's the tract.
So the temporal fiber don't cross. The nasal fiber cross.
Yeah.
The temporal fiber take the nasal area of the vision, and the nasal fiber take the temporal area of the vision. So they cross. The nasal fiber they cross, but the temporal fiber they don't cross. They go, where do they relay next?
Eddington-Westphal?
No. Lateral geniculate body in thalamus. So from where what happens? So any sensory, most of the sensory information they will go and relay in thalamus. They have to. Okay. So from there the information, where does it go?
It goes to the primal visual cortex.
So via
radiation,
optic radiation. Very good. So they go via the optic radiation. Where does the optic radiation go through?
Parietal?
So the part of it, the upper part of the optic radiation goes through the parietal lobe, and the lower part goes through the temporal lobe, okay, by the side of the lateral ventricle, and go and relay where? In the occipital cortex, okay, just above the calcarine fissure, okay. So above the calcarine fissure is the cuneate and the lingular part where they will relay, okay. So again, what is the role of thalamus here?
To relay the information.
So relay, just not relay,
Filter.
So that's why you see the things more, because you are expecting. Remember again the same principle. They receive more information from the cortex than actually what is going into the occipital lobe, because it is filtering the things, it's focusing the things what you need to see, okay. So if there is an involvement of the optic chiasm, what will be the symptom of the patient? So depending on whether the lesion is medially or laterally. So if there is a pituitary tumor, for example, in the optic chiasm, which will affect this middle part, so what will be the symptom of the patient?
Bilateral hemianopia.
So bitemporal hemianopia, okay. Whereas if there is a tumor by the side, so pituitary tumor causes bitemporal hemianopia. But if there is a tumor from the side which is pressing on the chiasm, what will be the symptom? Binasal hemianopia. Which condition you can get that? Usually hypothalamic tumor. But remember, this is much more common. If it is affecting here, what will be the symptom?
What?
Homonymous hemianopia with macular involvement, okay. But as soon as when it goes to the cortex, why do you get macular sparing? Maybe you can move over there. So in the cortex, when there is a lesion in the cortex, what is in the occipital cortex, what is the symptom?
Homonymous hemianopia with macular sparing.
With macular sparing. Why is that?
Is it because your eye can compensate?
No. Where did you keep the eraser?
Sorry.
So if I just draw quickly, because this is a concept you have to be very clear. So if you remember this pathway, so they go and relay in the lateral geniculate body. From there you get the fiber which is going through the parietal lobe and relaying in the cuneate part, and then you are having from the lateral geniculate body, these fiber are going through the temporal lobe and coming and relaying into the lingular part. So if I draw the lateral view of the brain. So what is happening deep inside the brain? If this is the lateral geniculate body, so some of these fiber are going as the optic radiation through the parietal lobe and coming into this part, and some of them is going all the way around like this and coming into the occipital lobe. Okay. But interestingly, the macular fiber go in the middle and they go to the tip of the occipital cortex. And this tip of the occipital cortex is specifically has got dual blood supply. Although this other part is supplied only by the posterior cerebral artery, this part is supplied by posterior cerebral artery as well as branch from the internal carotid artery. So in other words, this part has got both branches supplying from anterior and posterior circulation. So even if the posterior cerebral artery is blocked, because the supply is still maintaining the macular vision, that's why you get macular sparing. Whereas if it is affected here, it has got the macular vision, but it is supplied by single artery from the, it is usually which artery we have said? No, ophthalmic is here. It is the anterior choroidal artery. Remember I told you, it not only supplies the anterior choroidal plexus, it also supplies the optic tract. So if that is affected, then the whole macula is gone as well, because the macular fiber is still there. Is that clear?
So the cortex has to blood supply.
Yes, the occipital cortex,
Yeah.
not the other part. Okay? Yeah.
The anterior choroidal artery supplies the
Optic tract.
Okay.
And there is no second blood supply for macula there. Whereas in case of the posterior circulation, if it is in the occipital lobe, there is dual blood supply, and that's why you get spare. In stroke, obviously, that's why you can get, if this is affected, if the parietal lobe is affected, what can you get? Deeper part of the parietal lobe? Lower quadrantic hemianopia. So in other words, so if this is your field of vision, this is the, obviously your nose is here. So lower quadrantic hemianopia, it will be like this. Okay, one quadrant, it would be like this. Sorry. Is that clear? If it is in the temporal, it will be upper quadrantic hemianopia. So one half, but one half of the half. Is it clear?
Is it the top left half?
So
Yeah.
the other prior,
So yeah, if it is in the parietal, that would be the lesion. So normally, if it is here, what would be the lesion? Let's start from there. So if it is in the left side, it will be whole of this side. So if it is right and if it is left, the opposite side, it will be whole. That is clear?
yeah,
And the macula is involved.
yeah.
Okay. Now if it is in the parietal lobe, what will happen? It will only affect the lower half. The upper half is spared because the temporal fiber is still intact. Okay. And if it is in the occipital lobe, it will still be, if it is in the temporal lobe, what will happen? Yeah, this part will be affected, but this part would be, so if it is, it will be the upper part is affected, but the lower part is spared.
That's temporal.
That's temporal, top,
On both sides, right? Yeah.
on the both sides.
Is that this inferior and superior radiation?
Yes. Okay. And then finally in the occipital lobe, you will have homonymous hemianopia, but here macula will be spared. Macula will still be intact. Okay. So depending on the history, that will help you. Next important is third, fourth and sixth. What are the common symptoms?
Eye movements of fever.
So problem with ocular motility, that could be one, but more commonly ocular palsy. So what will happen with, so the patient might complain of double vision, blurring of vision, or even eye drooping of the eyelids. Okay, what are the common symptoms of third nerve palsy or signs of third nerve palsy?
Down and out.
So down and out. What else? Would you see that eye is down and out normally?
Yes.
No, because they have got complete ptosis. Unlike horn nuts, it will be a complete ptosis. Horn nut, you have to be, your mind has to know that this is horn nut. Then you can only recognize that. Whereas in case of third nerve palsy, it will be complete ptosis. In fact, you have to open the eyelid to look at the eyeball, which will be down and out. And what will happen to the pupil?
Constrict.
Dilates. So what are the fibers which are carried by the third nerve? So parasympathetic from Edinger vestral nucleus. What does the parasympathetic do? Constrict the pupil. When you are shining the light, that's why it's constrict. That's the parasympathetic component. So third, fourth, sixth common symptom is this problem with double vision, or you can get third nerve palsy, or you can get Horner's like symptom. Okay. So that's third, fourth, sixth. What about fifth cranial nerve? What are the components of fifth cranial nerve?
Which one? Sorry.
Fifth. Trigeminal.
Loss of sensation across face.
Loss of sensation on the face. Okay. What else? Do they only carry sensory?
The last muscles of
Dry
mastication.
mouth.
Eyelid.
Not
Swallow. Is it?
Not
No, they
swallowing.
can't.
Muscles of
Sensory
mastications. Okay. What are the muscles of mastications?
Temporalis
masseter.
and masseter.
What else?
Buccinator.
What else? Lateral and medial pterygoid. Okay. Which are the muscles which helps to close the mouth while chewing? So masseter, temporalis and medial pterygoid helps to close, and the only muscle which helps to open is the lateral pterygoid. So when a patient with trigeminal, when a patient has got trigeminal problem, so what would be the symptom? Loss of sensation in the face or problem with chewing. Is that clear? Okay. What next? Seventh cranial nerve. That's when I get stuck. So what are the common symptoms of second cranial nerve
They
palsy?
can't make they can't smile or make facial expression.
So problem with facial expression. Okay. So what is upper motor type of facial nerve weakness and what is lower motor type of facial nerve weakness? And invariably I get stuck here.
Do you get forehead sparing in one of them and not the other?
Yeah, so which one is which and why? Rose, come here and tell me why.
Oh no.
You know, it is 50-50 chance. But the thing is that if you don't know the logic, when it comes to 50-50, you will always choose the wrong one, somehow. Most of the time. You might be exception. So, you have told the right answer. Now, it is upper motor type of facial nerve weakness. What will be the deficit?
So you get mouth droop but no forehead sparing. So your eyes
Very
are
good.
big
So, but why?
because it's like got an extra track that's not cut off that supplies the forehead like the jaw. Oh no.
See, she has got a concept, but not clear concept. So, what is upper motor? What is upper motor neuron? Pri, what is upper motor neuron?
I don't know what definition though.
Lucy, what is upper motor? Nobody knows what is upper motor and what is lower motor. So what is lower motor? Let's forget about upper motor. What is lower motor unit?
From your like the muscle to the spinal cord.
So so from the motor nucleus, wherever it is.
Yeah.
Okay. There is obviously in spinal cord, but there is obviously in brainstem as well. Okay, motor nucleus. So from motor nucleus to motor nerve up to the myoneural junction. So if you have said spinal cord, let's stick to spinal cord. So if this is spinal cord, okay, where are the motor nucleus situated? In the anterior part, anterior horn cell. So here the motor nucleus are there. Okay. So from here the fiber comes. From here the fiber come and they go and supply the muscle, which will, so this part from the motor neuron to the motor nerve up to the myoneural junction is the lower motor unit. Is that clear?
Yeah.
So this is the unit of any movement. So that's the lower motor part. So now this part can do some activity on their own, but most of the activity what they do is controlled by higher center, which is called the upper motor. Okay, it can come from the cortex, it can come from the brainstem as well. Okay, so for example, there are pyramidal fiber which is coming from the cortex. There are extra pyramidal fiber which can come from the brainstems. Okay, which come from the brainstem, like rubrospinal tract, like vestibulospinal tract, like the pontine reticular fibers, like the medullary reticular fiber. These are the extra pyramidal tracts which is influencing this motor. But there are certain reflex. For example, knee jerk. Do you need the upper motor to do it? No. You are stretching it. There is muscle spindle. It is giving information and then it is contracting. So that's the lower motor unit. Okay. Now this lower motor is normally controlled by the pyramidal tract, most important tract. Okay. So the left side will be controlled by the right side and the right side will be controlled by the left side. Is that part clear?
Yeah.
Okay. Now we have got motor neuron in spinal cord, but we have got motor neuron in the brainstem. So what are the motor neurons in brainstem? Not upper. What are the motor nucleus which are in the brainstem? So what are the cranial nerves with motor nucleus? Tell me.
Trigeminal.
So from start, number 1, has it got any motor component?
No.
2,
No.
3,
Yes.
yes. 4,
Yes.
5,
Yeah.
6,
Yes.
7,
Yeah.
8, 9, 10, 11, 12?
Yeah.
Yes. Okay. So you can see all these has got motor component. So they must have got some upper motor control. Otherwise they cannot function properly.
Yeah.
Is that clear? So in case of the spinal cord, the right is supplied by the left, left is supplied by the right. So it is contralaterally controlled. But for brainstem, there is an exception. So what is that exception? All the motor nucleus in the brainstem are bilaterally supplied. But there is an exception to exception. So which are the motor nucleus which are not bilaterally supplied?
Facial.
Not the whole of the facial. The lower half of the facial nucleus is not bilaterally supplied, and then there is another nucleus in brainstem which is not bilaterally supplied.
It's a spinal accessory.
No. Another lower, which is most nearer to the spinal cord, and they behave like spinal cord. Hypoglossal. Okay?
Yeah.
Because it's quite near to the spinal cord, you can understand that it behaves like a spinal cord. But 7th is the real exception because it is much higher up. Still it is the lower half is only ipsilaterally supplied. So if we draw that, see, I know I would get stuck, but at least you have told the right answer. I'm pleased. Not knowing fully, not having full concept, but that's better than. Okay, so if I do like that, okay, that will be fine. It's good. So let's. So obviously the proportion is different than what actually is, but that doesn't matter. And now we will put a face here. You have to put a sad face, isn't it?
Why?
Because it has got facial nerve weakness. Okay, so now think of the motor unit first. So where is the facial nerve motor nucleus present? Which part of the brain? Not medulla. Pons. Okay, so that's where it is sitting, and from there the nerve is coming. Okay, which is supplying the face.
Yes.
And the lower motor part is this nucleus, the nerve up to the myoneural junction. Is that clear? Apart from this motor fiber, what does the facial nerve nucleus carry? So that will be only in the lower, along with this motor nerve, the facial nerve carry other fibers as well. What are they?
Sense.
Parasympathetic for
The glands.
Which glands?
Apart from
Sibling.
Apart from pituitary, all. Very good. Not pituitary.
No, the
Parotid.
that's
Apart from parotid, all. So
it, yeah.
lacrimal, submandibular, sublingual. So that's one. What else?
Special sensory.
For
Anterior 2/3 of the tongue.
very good. So taste sensation from anterior 2/3 of the tongue. What else?
General sensory.
General sensory from
The ear.
yeah. Okay. Anything else?
And then they're the motor fibers.
Yes, or the motor fiber. So if this nerve is affected, it can not only affect the motor part, but all the other component can be affected as well. Is that clear?
Yeah.
But whereas if the nucleus is affected only, you would only get motor problem. None of the other will be affected. Okay. And when the upper motor, so now let's come to the upper motor fibers. Okay, so when you have to make a face, especially pyramidal means you are doing it intentionally. You are asked to smile in camera. So that is a pyramidal tract which is supplying it, because there is another fiber. I'm not going in, not make you complicated. Okay, so what is the real disposition is like this, but there won't be any fiber on that side. Is that clear? Upper motor, what I told you?
Yeah.
The upper part is bilaterally, but lower part is unilateral. Lucy, you still look a bit dazed and confused.
Yeah, I'm just quite confused.
Why is that?
I'm not really, so you know how we were on about the motor nuclei earlier and there was like 3, 4, 6 and 12? I just don't understand where this one's come from.
Which one is coming from?
The 7th one, the facial one. Is
Seventh
that
is-
alongside the 3,
No,
4, 6?
3, 4, 6 has got only pure motor component. Now, if you look at the 7th, 5th, these are branchiomotor nucleus. I didn't go. So, 5th, 7th, 9th, 10th, they are not just voluntary. They are not just motor. They have got a bit of. So, for example, when you swallow, okay, that's the 9th and 10th.
Yeah.
You swallow, you can do it voluntarily, you can do it involuntary as well. So it has got branchiomotor nucleus, not pure motor. It is branchiomotor. Same with 5th, when you are chewing, part of it you can do voluntary as well as involuntary. And even the facial expression, part of it, if you are thinking something you don't like, your facial expression change. Okay, which is involuntary, like emotional pathway. And then you can do voluntary as well. So these are branchiomotor. So although these 5th, 7th, 9th, 10th, 11th has got motor, but they are not pure motor. Pure motor is 3rd, 4th, 6th, 12th.
Yeah.
And these are branchiomotor. Still they have got motor, but these are called branchiomotor.
Okay.
That's why it is not, and these are not present medially. These are present slightly laterally.
Okay.
So, that's a very good question. That again, you need to go even more basic for the brainstem. I'll discuss one day. So what are the motor nucleuses, types of motor nucleus there? So what are the types? Just tell me the basic type of motor nucleus. One can be somatomotor, okay. One can be, which is visceromotor. So what does they do? Visceromotor, what is their main function? Controlling the gland. Okay, like the your lacrimation, like the salivation. These are visceromotor. Okay, then there can be mixed varieties. So I'll discuss that one day. Okay, so even for the sensory, there is so any then it can be so there can be special somatic motor. Then the sensory it would be like that. So that's why it is different. But it's if it is a motor nucleus, it has to be controlled from the upper motor fiber.
Yeah.
Okay. Now, if you have got a stroke, which is
Quick question. So are all the motor neurons in the brainstem are upper motor?
no. All the motor nucleus in brainstem are the part of the lower motor unit,
Okay.
but they are controlled by the upper motor, which is bilateral in all the motor nucleus except the lower part of facial and 12.
That's good.
Okay. So if this person, if he has a stroke on the left hemisphere, what will happen?
You lose the upper motor control to the right side.
So what is happening? If there is, so if let's do another picture. So you see the control here. From same side, it will be here. That will be here, and that will be here. So if you have a stroke upper motor in the cortex or anywhere along this before it has reached the nucleus, so what will be the, so this patient has got a stroke on the left cortex. What will be the symptom for this patient?
Right-sided face view.
Which side? Is it both upper or lower, or the whole of the face on the right side?
Just the lower.
Just the lower. Why is that?
Because you've still got some.
So you have got this fiber still supplying the upper part.
Okay.
Okay. Whereas if it is anywhere here or here, the whole of the face will be affected.
Yeah.
So in lower motor you get the whole face affected, and in the upper motor you get sparing because it's still there is some fiber left. Is that clear, Ben?
Yeah.
Okay. Along with that, if it is in the what we call the lower motor type of facial nerve weakness, although it's called lower motor, it carries other fibers. So on top of the motor, you can get loss of sensation in the anterior 2/3 of the tongue, loss of taste sensation in anterior 2/3 of the tongue. You can get loss of sensation in the pinna. You can have problem with secretion of the glands. Whereas if it is upper motor, all this, there is nothing to do with that. So they won't be affected at all. Okay, clear? Lucy, have a
Is the
read.
blue line coming down to is that the upper motor?
Yes.
And then the nucleus itself is lower, and then everything beyond that's lower.
Lower.
So in the upper motor you get a sparing of the some sparing. With the
Yes.
lower motor, the whole face. is
Whole of the
affected,
face will be affected.
as well as other, like every function.
Yeah, it depending on which level it is affected, the other thing will be affected accordingly.
Okay.
Okay, it's not always have to be everything. So that's 7. What about 8 cranial nerve? What are the common symptoms?
Vertigo.
So loss of hearing
Embarrassed.
and problem with vertigo or disequilibrium syndrome.
Okay.
Okay, we have discussed about that. What is disequilibrium? What is vertigo? What about 9th and 10th? What are the common symptoms?
Difficult to swallow it.
Difficulty in swallowing, and then they can have
speech.
other autonomic disturbance as well. 11th, yeah, so another is they can have dysarthria, not speech.
Yeah.
So dysarthria or dysphonia, more specifically, dysphonia if the larynx is affected. Okay, what about the 11th? What would be the problem? Moving the neck or shrugging the shoulder. 12th,
Can't move the tongue.
yes, problem with moving the tongue. So these are the symptom complex for the cranial nerve. So we have discussed the higher mental function, we have discussed the cranial nerve, we have discussed the motor, we have discussed the sensory. What next? Problem with coordination, problem with ataxia, okay, walking, problem with, so these are the important for the cerebellum. Then they can have problem with speech. So what are the types of speech problem you are aware of?
Dysphagia.
So one is dysphasia, which is problem with language processing. What next?
Slurring.
So dysarthria, where the speech is processing is okay, but it appears slurred. Okay. What is the third type? Dysphonia, problem with producing the sound. Okay, although it can present as this problem with speech. So these are the problem they can have. Is that clear?
Could you just go over them one more time, please? Language processing.
Is dysphasia.
Aphasia.
Problem with articulation is dysarthria.
Yeah.
Problem with producing the sound is dysphonia. Dysphonia is specifically for the larynx.
Okay.
Okay. What next in history? We told about, apart from this, for example, if there is autonomic symptom, if there is headache, if there is seizures, if there is loss of consciousness, all this you take in the presenting complaint. But remember, in exam, if you have to take each and everything, you will never finish.
Yeah.
Okay. So remember this structure. So once you have taken the presenting complaint, remember to finish the structures in the past medical history. What are the things you are focusing on if you suspect that this is a stroke?
Risk factors, so
Exactly.
blood
So
pressure,
high blood pressure, atrial fibrillation,
Smoking,
smoking, diabetes. Then is there any previous history of bleed which can indicate cerebral amyloid angiopathy? If there is any medications which are response which can be responsible for bleed, like antiplatelet, anticoagulant, and then you are taking the history of any family history of aneurysm or AV malformation, etc. Okay, so all the past medical history. Now another important thing in past medical history, if somebody say I'm there is diagnosis of hypertension. The important thing is not only hypertension, whether it is controlled, whether they are taking the medications regularly. Okay, so that's something we need to explore carefully. Okay, so after that, obviously family history is very important, but you have to see whether there is a history of stroke at young age. That is more likely to be familial. Otherwise, sometimes it could be familial, it won't be. But if it is, usually if the stroke is below 50, we think of always, is there a familial cause for it? Okay, and then in history, allergies in general, and then social history. The important thing in social history, apart from everything else, what is their occupation, is driving, because that will affect their driving. Even a TIA patient cannot drive for 4 weeks. Anybody with a stroke or TIA cannot drive for 4 weeks. Okay, and after 4 weeks, if they have recovered, can drive. They do not need to inform the DVLA, but they do need to inform the insurance. But beyond 4 weeks, if they haven't recovered, they have to inform the DVLA and the insurance before they can go back to driving. Is that clear? So that concludes the history taking. Okay, can stop here.